Okay, hi. This is the Unit 5 recap on diabetes mellitus. You will have about 15 questions on diabetes, and then there is a GI assessment question in there. So make sure that you do review your information from your lab, go into your Canvas in lab and your syllabus and your CPE checklist for your GI assessments, okay? All right, so we'll go ahead and start off with what is diabetes, both type 1 and type 2. We know that diabetes type 1 is an autoimmune process whereby we have the pancreas producing no insulin or very little insulin. So the diabetic type 1 will require insulin injections. We don't really know what causes this autoimmune response, but that's what's happening. And there's a theory that it may be a viral infection, but we really don't know. That's why it can occur at any age. So how do we manage diabetes type 1? We are going to, all diabetes, of course, we know it's going to be diet and exercise. And then we know, of course, this one's going to require the administration of insulin. In type 2, we have a situation where we have decreased sensitivity to insulin or insulin resistance, and we may have pancreas that are either producing or overproducing insulin, or they're not producing sufficient insulin too. And this usually happens with the production of insufficient amount of insulin. It happens with those individuals that have had diabetes type 2 long standing without it being diagnosed. So eventually the pancreas quit functioning as efficiently as before. So what are the risk factors? This is where we do look at risk factors for diabetes. We know that age is a risk factor, so we say you're at risk if you're 45 or um, older, okay, 45 years or older. Overweight plays a big role. Inactivity or a sedentary lifestyle. If you have blood pressure or a high cholesterol, those are also risk factors. If you have a family history, that puts you, that's a risk factor. Or if you're of African American, American Indian, Asian American, Hispanic, or Pacific Islander descent. Those are the risk factors. And in them, there are some that are modifiable, but some that are not. We can modify the weight, the inactivity, our blood pressure, and cholesterol, and the other ones are non-modifiable. So how do we manage type 2 diabetes? We actually start with diet and exercise. We didn't used to start oral anti-diabetics until later. We just tried to regulate it with the diet and exercise. But the current practice is to start them on metformin. Okay, so which does not work on the pancreas but works on the liver to reduce the production of glucose, but more importantly with type 2 diabetics is that it also reduces the insulin resistance. So diet, exercise, metformin, other oral antidiabetics like the sulfonylureas, and of course insulin if those three, the combination of those three do not work. A type 2 diabetic may go on insulin. It does not mean that that's it, that they're going to be on insulin from now on. Okay, the diabetes or management of diabetes. First of all, we want to maintain as near normal lab values as possible. So according to the American Diabetic Association, we're looking at maintaining a fasting blood sugar between 70 to 130, a 2-hour postprandial blood sugar that's less than 180, and a A1C that's going to be at 7 or below. Okay, so those are the goals. Those are the lab value goals for managing the diabetes. Okay, the other thing that we look at is diet. Diet, of course, and exercise, they play a big role. So diet can include, and this is difficult, teaching them about what diet plan or diabetic diet plan to follow. There are really different types that can be followed. You can have, there's basically 3 methods. You have the plate method, you have the carbohydrate counting method, and the glycemic index method. With the plate method, what we're doing is we're using a visual or a visualization where we have the plate and we actually divide it into 4 quadrants. One of the quadrants will be proteins, one will be for grains, one will be for fruit, and one will be for vegetables. And this is what we teach the diabetic to go ahead and manage their diet by using this plate method, this visual method. Of course, we're also going to teach them to choose the good carbs or complex carbs versus the simplex carbs. We know simplex carbs are such things as candies, your desserts, juices, those types of things. So we really want them to choose the more complex ones like grains. Um, we may have a cheesecake because it does have some fat and protein in there, so it slows it down and stuff. So we want them to be choosing complex carbs. Actually, the diabetic diet, we're saying that up to 60% of the diet will be carbohydrates. And then about 30% will be fat, and 10 to 20 will be protein. So it's a high carbohydrate diet. It's just a matter of choosing the complex carbohydrates instead of the simplex ones. Now, if they're following the carb counting method, we say that 15 grams of carb equals 1 serving. And so the number of carbohydrates are going to be specified there for the individuals. It's, you know, it's planned individually according to that person's needs and activities and so forth. Normally, what we say is that a meal will consist of 45 to 60 grams of carbohydrates, and a snack will consist of 15 to 30 grams. But it is specified individually. Now, what we do teach the diabetics, so far as diet is concerned, to eat the regular meals, following whichever, whether it's carb counting, whether it's the plate method, whether it's glycemic index, which I'll touch a little bit on in a little bit. But we also want them to practice eating snacks, so for them to have a mid-morning snack, a mid-afternoon, and a bedtime snack. And that's because we want to maintain as normal a glycemic index as possible and eliminate or reduce the number of peaks and lows that they may have with their diet and their activities. So we want 3 meals and 3 snacks. Okay, so the glycemic index one is really looking at the types of carbs that the person is eating, and the goal is to eliminate the high glycemic foods. The South Beach diet is a perfect example of this type of diet. So we're looking at teaching the person to eliminate processed or enriched food products. We're teaching them to avoid what we call the white carbs, because those have a very high glycemic index, such as breads, potatoes, pasta, and rice. What is very important, no matter what type of diet that they follow, they need to learn to read labels so they can go ahead and determine how many carbohydrates are in a serving in the products that they buy. Keeping in mind, we teach them that 15 grams is equal to 1 serving. Okay, so far as exercise is concerned, we are teaching our diabetics to obtain 150 minutes of exercise per week. If they want to go ahead and do it in 30-minute chunks for 5 days out of the week, that's fine. But the goal is for the time to add up to 150 minutes in 1 week's time. We do advise them to go ahead and, especially if they're just starting off, to start off with moderate type exercise. And this would be, of course, a perfect example would be walking. But they can do the treadmill. They can also do a stationary bike or bicycling, swimming, but moderate exercise, and not to start with those really vigorous. And then they can build up, but up to 150 minutes. Now, with the exercise guidelines that we give them is that we want them to hydrate. So they are to drink plenty of fluid before they start exercising. During their exercising, we say actually every 15 minutes for them to drink water. And then afterwards, we want them to stay well hydrated. As we know, diabetics tend to be in the dehydrated side. We also want them to check their glucose before they start their exercise program. If their blood glucose is less than 80, we tell them to go ahead and eat a protein snack, recheck their blood sugar to make sure that they can go ahead and do their exercise. If their blood sugar is greater than 240, we tell them do not exercise, to go ahead and delay it until they have their blood sugar under control. We want them to go ahead and have a source of glucose with them, quick glucose. So hard candies or a regular drink, cola or a juice, to have it with them. And we want them to also, if they are on insulin, to make sure that they do not exercise during times when their insulin will be peaking. Speaking about determining when their insulin is peaking and stuff, of course, we're going to tell or instruct the patient to closely monitor their blood sugars. They need to know that a fasting blood sugar does not suffice for giving them a picture as to how well they're managing their diabetes, because they could consistently have a low blood sugar, but that doesn't mean that the blood sugar is within desired limits throughout the day. So we are teaching them to go ahead and at minimum to check their blood sugars 4 times a day. That would be before meals and at bedtime. Okay, pharmacological, we're going to, with the diabetic, we're looking at oral, and then of course we're looking at insulin. With oral, we have 3 types of medications. We have the sulfonylureas, which stimulate the pancreas to secrete insulin. So a patient has to have functioning pancreas, pancreas producing that insulin because they will stimulate. That's how they work. And then we have the biguanides. This is for metforminols. And this medications inhibit the production of glucose by the liver, but more importantly, they help to increase the body's sensitivity to insulin. In other words, they work towards reducing that insulin resistance. And then we have the alpha glucosidase medications, and those ones, they work on the gut. They delay the absorption of carbohydrates into the intestine, thereby slowing the entry of glucose into the bloodstream. Important to note that if somebody is on that type of medication and if they suffer a hypoglycemic event, they need to take a pure source of glucose, because if they take a carbohydrate like candy, hard candy, the absorption is going to be delayed into the intestine. So it's not going to work rapidly like we want it to. But if they take a pure form of glucose, we won't have that problem. So they need to carry with them glucose tablets or glucose gel. Make sure that you do review your different types of insulin. They can be found in table 67-9 on page 1431 of your books. Also review the mixing of insulins. Those that can be found in table 67-10 of page 1433. The thing to remember with mixing of insulins is that we're always going to draw the rapid or fast acting insulin first before we draw up the intermediate or long acting. Make sure that you also review about injection sites. We have different injection sites, but what we do teach the person about insulin administration is to rotate sites within one anatomic area, and that's to prevent any changes in absorption, which will occur if the person rotates, say, between injecting in the abdomen and then the thigh, then the deltoid. They have different rates of absorption, okay? So we want them to stick within one anatomical location. Okay. Other things that you know about insulin that you need to teach your patient is read the labels, of course. And if they are using whether they use the insulin pen or whether they're using insulin vials, it's important for them to date them when they do open them and start using it. Once they are open, the vial or the flex pen, they are to be stored outside of the refrigerator before they start using them. If they're not unopened containers, then they can be refrigerated, and that will keep a longer shelf life for them up to the expiration date on the vial or the pen. All right. Otherwise, once they're open, they're good for only 28 days. Okay, foot care. Lots of things that we teach, and we know that the feet, that's the primary area for problems with diabetics. Because of the vascular changes that occur, both macro and micro. Micro are the ones that damage the small blood vessels and the nerves. And macro is the one where we have buildup of fat deposits, or we have clot formation. So the legs suffer a double whammy, all right, because we have the neuropathy from microvascular changes, and then we may have the peripheral arterial disease from the macrovascular changes. So it's no wonder that a lot of our diabetics end up with having some sort of amputations performed in their lower extremities. So foot care is very, very important. We are going to teach them to inspect their feet daily, and to look in every single crevice in between the toes and everything, and maybe even use a mirror so they can better visualize. We're also going to teach them to wash daily with lukewarm water and mild soap and dry well between the toes. Pat dry, do not rub dry. We're going to have them teach them to apply lotion on their heels and on the top of their feet, but never in between the toes. We never want them to go barefooted. We want them to wear shoes indoors and outdoors. They must be comfortable shoes. We teach them to buy their shoes in the evening hours and not the morning hours, so they avoid situations where they buy shoes that by the afternoon are very tight and are uncomfortable. It's not a good fit. They are never to wear open shoes or sandals because of the injuries that they can sustain to the heels or to the toes. We want them to clip their toenails straight across. We don't want them to use hot water bottles or heating pads. If they were up north and used, warming blankets or electric blankets, we wouldn't want them to use that. We don't want them to submerge their feet in a hot tub of water. No submerging of feet. We want them, when they go to the doctor, to go ahead and remove their shoes and actually expect of their doctor to inspect their feet with each doctor's visit. And then we want them to make an appointment on an annual basis to see the podiatrist. Another thing with diabetics, we teach them to wear what we call diabetic socks, which would just be light colored socks, and the type of socks that don't have those huge seams, so that very fine seams, so we avoid the rubbing or the pressure that can occur from those seams. And the reason we have them to wear light colored socks or white socks is so that they can easily spot any drainage that they may have on their feet, and they may not be aware that they have a sore or they have some kind of object embedded in their feet, because we know the loss of sensitivity is very common with diabetics. Okay. And that's on foot care. Sick day rules. If somebody is sick, if our diabetic patient is sick, we're going to teach them to monitor their blood sugar. So this means we want them to check their blood sugar every 4 hours. We want them to call the doctor if that blood sugar is staying over 240 or if their symptoms do not improve. We want them to test for ketones if they're type 1 diabetics, and call the doctor if they have an amount that's greater than small. So if they have a moderate amount of ketones, we want them to call their doctor. We want them to get hydration, so drink 8 to 12 ounces of sugar-free liquid every hour while awake. If they cannot eat solids, then we tell them it's okay to just drink, sweetened liquids. It's okay, then have a regular Coca-Cola, have juice, have regular milk. We want them to get something down, all right? And that's if they cannot eat any solids. We want them to call the doctor if they cannot keep the food down for more than 6 hours. We want them to also call the doctor if they have persistent diarrhea and progressive weakness, or they have persistent vomiting, or if their blood sugar is greater than 300 on 2 consecutive finger sticks, or they're spilling the ketones. And lastly, we want them to know absolutely that they are to continue taking their medications as prescribed, not to hold them, not to skip them because they're vomiting or anything like that. They are to continue with their medications. Okay, the next section here is on hyper and hypoglycemia, recognizing it and how we manage it, okay? The hyperglycemia clinical manifestations, this is where you remember the 3 P's. The polyuria, which is excessive diuresis that is occurring because the body is eliminating the glucose molecules. So along with the glucose molecules with the osmotic pressure, it's going to be pulling the fluid, and so we have excessive frequent urination. We have polydipsia, or the thirst, excessive thirst, because we are losing a lot of fluid. So we have that thirst. And then we have the polyphagia, which is excessive hunger, because the body is triggering our brain, or the brain is saying, hey, I'm not getting nutrients. And it's not because I don't have a dietary intake, it's because I just do not have the insulin to get the glucose into the cells. So we get hungry, or excessive hunger, we eat more and more and more, which only compounds the problem. So those are the 3 P's. Because our body then turns to burning fat, the next source of glucose for the body. The first source would be the carbohydrates. The second source would be the fat. And so the body turns to burning or metabolizing fat to obtain glucose or energy from that. And we're going to, in essence, be losing weight. So the hyperglycemic person will have weight loss, and it's going to be unexplained weight loss. They're not doing anything to lose those pounds. They're just losing them. And as a matter of fact, they may be eating excessively and still losing weight. And of course, they're going to have the dry mouth and then the fatigue. Remember, key is the Kussmaul breathing, especially if they're type 1 diabetic, all right? That means that they have excessive ketones. That means they're burning down the fats, and if they're type 1 diabetic and they're burning down fats, then they're at high risk for developing diabetic ketoacidosis. Kussmaul breathing is a way for the body, it's rapid, deep breathing, and it's a way for the body to eliminate acids, all right? Other signs and symptoms for hyperglycemia may be a blurred vision, all right? Which is, you just don't go by the blurred vision itself, because hypoglycemia also can elicit blurred vision, okay? But those are the signs and symptoms for hyperglycemia. How do we manage it? Well, the way to manage it is to make sure that we have the proper diabetic medications, that we take them, that we don't skip them, that we reduce the number of carbs, that we maintain a well-balanced diet, a diabetic diet. And if the person, we tell them, they are in a persistent state of hyperglycemia, then they need to go see their doctor to see what changes or modifications need to be done on their diet and, of course, on their medications. The other one, I'm going to skip on down to hypoglycemia. The clinical manifestations of hypoglycemia, you do need to be able to differentiate between hyper and hypo, okay? Hypo, we're going to see what we would see if we have an adrenaline rush, because that's what it elicits. Our blood sugar drops and it elicits a sympathetic nervous system response. So we're going to see the clamminess, the sweating, tremors, tachycardia, or a person may say, I'm having palpitations, the nervousness. Hunger will be there. So those are all nervous system, not nervous system, but sympathetic nervous system response. An adrenaline rush, that's what you would get with it. The person may also complain of feeling lightheaded. The other thing, then we start seeing some central nervous system problems, or, we're actually that we see that the lack of glucose is affecting our central nervous system. And so what we're going to see is decreased concentration, that numbness around the lips and the tongue. The person may be confused, disoriented, may be suffering or exhibiting slurred speech. In other words, they'll look like, and especially if they're type 1, they may look like they're, and sometimes they are mistaken for that maybe they're inebriated, okay, because of the confusion, disorientation, lightheadedness, and slurred speech. And so they seem like they're on something, some kind of high, right? They may also then suffer seizures and, of course, the loss of consciousness. And like I said, blurred vision is also there for hypoglycemia, okay? Now, what do we do with hypoglycemia? That is a little bit, we can correct it a whole lot quicker than we can correct a hyperglycemic event, all right? With hypoglycemia, of course, what they need is glucose. And so we treat it, we give them 15 grams of glucose at a time. That would be either a half a cup of juice or soda, a cup of milk, a tube of glucose gel, 4 glucose tabs, 3 to 5 hard candies, or even 6 hard candies. But what we have the person do is to recheck the blood sugar every 15 minutes. So they take 15 grams of carbs and then they recheck their blood sugar. And they are to repeat it if the blood sugar is less than 80. Now, if their blood sugar does not get better after 30 minutes, then we ask them to contact the doctor. Now, some of the things that you do, if their meal is, or it's more than 1 hour, an hour or more till their next meal, we have them eat a snack. And a snack will consist, usually the best thing is a half a sandwich and a half cup of milk. You know, the sandwich can be either with peanut butter or with cheese or with, luncheon meats, cold cuts, and then the half glass of milk. And then if it is close, less than an hour, close to their next meal, then we have them just go ahead and eat their next meal. All right? But that's on what we do to treat hypoglycemia. Now going back over here to the Somogyi versus Dawn phenomenon. The Somogyi effect results from nocturnal hypoglycemia. So we have a person that at nighttime while they're asleep, their blood sugar drops. And so it is the body's response to that hypoglycemia. The liver will release the glucose, all right? And so they end up waking up with hyperglycemia. So the cause is nocturnal hypoglycemia. So how do we manage that? Normally by making sure that they have a bedtime snack to carry them through the night. Now the dawn phenomenon is a normal physiologic process, all right? So what happens for every individual that at dawn around 4 o'clock or so, the liver will release glucose. And this is built into us. And so the liver does that to give us that little bit of energy upon arising and get us going for the day. That is a normal physiologic process. However, diabetics, when the liver releases that glucose, then it causes a hyperglycemia state in diabetics. So how are we going to manage this? What we need to do, usually what the doctor does, is the doctor will increase the insulin, the dosing of insulin, and usually to make sure that there is sufficient insulin at that hour when the liver automatically normally triggers that release of glucose. There's sufficient insulin on board to prevent that state of hyperglycemia. So that's Somogyi and dawn phenomenon. Somogyi is because I dropped my blood sugars during the night, nocturnal hypoglycemia, and usually, I slept through it, so I didn't even know that I had it. And the other one is I don't have enough insulin on board to handle the normal release of glucose by my liver at dawn, all right? So oftentimes what we do and what doctors will do is we'll have the patients get up at 2 o'clock, 2:30 in the morning and do blood sugar so that they can see, are they suffering hypoglycemia at that time? How low is the blood sugar getting? Or is it not? So that it helps them determine whether it's Somogyi or whether it's dawn phenomenon. And then that way they know which way to go in treating it or what adjustments they need to make. All right, the next one on there is the hypoglycemia unawareness. And this happens with people that have been diabetics for a pretty long period of time. And maybe they've had frequent episodes of peaks and valleys, highs and lows of blood sugar, so that they have this frequent episodes of hypoglycemia. And what happens is that the body usually finally stops responding to those episodes of hypoglycemia. So we don't have the usual warning signs that we experience with a hypoglycemia because the body no longer is responding to it. And so we say that there is hypoglycemia unawareness. Okay, the next thing that I have on here, that's it on diabetes. Short and simple, right? The next thing here, I thought I would go ahead and put here about your GI assessment. I just pulled this out from your CPE on the gastrointestinal assessment. And it has on there really what it's looking at is assessing the abdomen So you know that the very first thing that we do is that we inspect, we visualize. We look at the abdomen for any masses, lesions, the size, symmetry, contour, any dimpling, any discolorations, anything that is out of, out of sync of what we expect to see. So we inspect the abdomen. And then we are going to listen. We are going to auscultate all four quadrants for the presence of vowel sounds. We need to listen. Usually it takes about a minute. But if we don't hear anything, then we're going to listen in an area for 5 minutes before we decide, yeah, there's no vowel sounds. We are also going to listen for any bruits or hums. If we do hear a bruit, we need to report that because actually what we're listening to is a problem. The bruit is coming from the aorta, all right? So we listen for that. And sometimes we do pick up on that. And then after we listen, then we're going to percuss. Percussion is done for masses, to feel masses, for organs, to palpate your organs to see if they're enlarged. And we also percuss for ascites because percussion will tell us the difference between air and fluid or air and solid, okay? It's a pitch that we percuss for. So we also percuss for ascites. And then we come to the palpation. You, of course, are only responsible for doing light palpation and not deep palpation, but we have both of them. Palpation is the very last one because what we're going to do with palpation is that we're going to elicit tenderness. If there's tenderness in the abdomen, we're going to increase it with our palpation, and we're going to increase peristalsis, all right? So palpation is the very last thing that we do. All quadrants and the inguinal area are palpated for tenderness, any distension, any muscle resistance, any bulges that we may feel. And then, of course, we're going to ask them, we're going to inquire about the date, the amount, color, and consistency of their last bowel movement. This is what you have in your CPE, but another piece of the GI assessment that you don't have in your CPE is that you're going to ask them about their intake. We're asking them about their elimination, but we're going to ask them about their intake. So part of the GI assessment is how well do they eat? Do they have all their teeth? Are they able to swallow properly? That's all part of gastrointestinal assessment, okay? So that concludes your Unit 5 recap. If you have any questions or you need further information or have a question for me, of course, you know to email me. All right. Thank you very much.